Thank you so much to the organizers of the KRA conference for giving me an opportunity to discuss providing dialysis in this COVID epidemic, a bit of science and a bit of practical aspects that we were able to do and been able to do during this epidemic. Is it working? For a long history, for a long time, humanity has had to contend with many epidemics. Or do you want to move for me? Next. And next. And as per September, I believe by now it could be about maybe 250 million people worldwide have been affected by COVID-19 epidemic, and almost 5 million people have lost their lives. And next. Previously, at the beginning of the epidemic, of course, there was a lot of emphasis on the pulmonary aspects of the COVID-19. But of course, by now, all of us know there are a lot of extrapulmonary manifestations of COVID-19, especially now on thromboembolism, cardiac, renal, and almost every other system we now appreciate has been affected by COVID-19. Next. So providing dialysis during this time of COVID-19 has had many aspects. There are a lot of patients who are developing acute kidney injury, and the professor alluded to this very well yesterday. A lot of people have developed acute kidney injury, and even yesterday we discussed through many mechanisms that people are developing that, and that has caused an increase in the need of provision of dialysis services. Then there were already the patients who are on maintenance hemodialysis. Just because there were new patients who required the dialysis from AKI did not chase away these people. The need remained there. And there was also provision of extracorporeal therapies. I think we'll have 1 or 2 speakers discussing this, still being provided under dialysis services. So I'd want to begin with acute kidney injury and dialysis. And many studies are out there, and they have shown that AKI is common. This study in New York showed up to 37 of patients who were admitted in New York hospital in 13 centers. That is about 5,000 people with COVID. 37% of these patients had AKI, and 14.3% of these patients, they required renal replacement therapy, and 89 or 90%, that is 9 out of 10 patients on mechanical ventilation developed AKI. So that means if you are, you have 1,000 people on ventilators in a country or somewhere, then a very high number of those people required to be dialyzed. And unfortunately, the numbers of the people who died who had AKI was high, up to 35%. Another study, this was in Germany, showed the up to 6% of the people required dialysis. And unfortunately, 73% of patients who are ventilated and required dialysis died Another study, I think this was one of the early studies from China, and was showing a bit of a low percentage of people who had AKI, but other studies that were done in other countries were showing the AKI was much higher than this. Study from South Africa that showed, I think there were 4 hospitals related to this. And out of the patients, out of 86 patients, I don't know how many people were all who had COVID, but out of all those 86 had the AKI, and out of these 48 people required dialysis, and unfortunately 47 of them died. That's a very high mortality rate. On people who had chronic dialysis in their, I think 4 centers, they had 295 patients who were undergoing maintenance hemodialysis. 31 tested positive for COVID-19, and unfortunately 6 died. And this was one of those papers that was showing a bit of like reverse epidemiology, whereby the patients with the AKI were dying more than the patients who were on chronic hemodialysis. So providing dialysis during this time has come with various challenges, which pushed and have pushed many institutions and facilities. Some are COVID specific, like surge in numbers, high AKI rates. Then there was issues of personnel where there were limited trained nurses, limited biomeds, sick offs and quarantine for a staff, whereby maybe you have 10 renal nurses and you're told 3 on sick off or isolation, leaving other fewer staff who now suffer burnout. And unfortunately, many colleagues have also been lost during this epidemic, and we can attest to that as an association. There were issues of limited dialysis machines and even consumables because of the high utilization, and also some of the imported consumables whereby the countries that make them were maybe even hit harder than ourselves, and they are not able to supply these consumables as efficiently as they were able to do before. In summary, is that the AKI in COVID was common and is common, and it was higher in mechanically ventilated patients. The mortality was higher, and the need that arose was there is increased need to dialyze patients with AKI, and there was shortage of dialysis equipment and staff. And one of the things I could have added here is that all this needed to be provided in an isolated aspect and could not be done as business as usual. So in such times, what could be done, or what can we do to ensure that this crisis does not overrun us? Or even if this crisis is there, how do we mitigate, or how do we survive during such a crisis? And I thought there were 3 aspects that are interrelated: human resource, dialysis methods, and dialysis supplies. So under human resource is that some of the need that is there and was there, and we really do not know, we never really expected there will be a 4th wave like we have experienced. And for sure, even now, we can only hope for the better, but we don't really know how the situation will be. So in terms of securing human resources to provide dialysis during this COVID-19, is that we need to provide the appropriate PPEs for the staff who are working. And I'll summarize with a bit of the experiences that we had at KU. Provide appropriate PPEs. This is to protect your staff. Otherwise, if you fail on this aspect, very soon, a lot of your staff whether they are biomed, nurses, doctors, you'll find they have taken sick offs and they have gone for quarantine and isolation. Cohort staff and their shifts, so that if they dialyze people maybe on this shift on Monday, give them another shift maybe on Wednesday, and try and keep that shift, so that if one of the staff from that cohort is unwell and has unfortunately spread COVID-19 to the other staff, then they don't have to affect all the staff. And of course, many departmental meetings have been discouraged, especially in small groups and small areas. Social distancing of staff, especially meals and working desks, where the staff are encouraged to have their meals at different times. And if possible, sometimes it's not possible for them to have different areas to work on. In the critical care units, consider having a renal or a dialysis corner in the critical care unit, so that one renal nurse or staff can be able to attend several patients simultaneously, as opposed to having the patients who require dialysis distributed maybe in a very big ICU that ends up requiring many nurses, and we do not have those nurses. There are some people who tried this kind of extension cables and bloodlines to help running of the CRLT machines out of the room where the patient is dialyzing. And these measures to try and reduce the exposure of the nurse, who has to spend a lot of time. Of course, there were some ICUs that were very advanced. They have sanction, they could sanction the rooms and extract the air, but some of the simple aspects would be providing these extra extension cables for people who have the CRLT machine. Telemonitoring, some hospitals have taken that very well, whereby there are a lot of CCTVs and monitoring outside the renal unit, outside the door or outside where the patient is dialyzing, and the nurse can be able to monitor the patient out of there. Some countries and even here have considered the regional enrolling of outpatient nurses to be able to offer inpatient dialysis. Dialysis methods is that one of the things that you could consider is doing of SLED, especially on the patients who are requiring CRLT and it is not possible. And for patients and facilities that have CRLT machines, they could use prolonged intermittent renal replacement therapy. This is whereby the usual CRLT machines are used, but because sometimes they may not be sufficient, instead of 8 being continuous for the 24 hours or 18 hours, then it's done maybe for 12 hours and the cartridge is changed and another patient is dialyzed. All these things are not perfect, but it is trying to deal with the crisis. In the literature, I have read about peritoneal dialysis. I'm not aware if there is any center in the country. If somebody has experience, they can tell us that later about doing peritoneal dialysis. But I have read in some countries who are able to do peritoneal dialysis for their patients. This is because it requires less infrastructural setups, and some centers were able to quickly put these peritoneal dialysis catheters, and this dialysis was able to be run by many nurses who were quickly trained, and they were able to offer the dialysis during the COVID-19. Finally, this is what I read. I don't have experience about it, about continuous arteriovenous hemofiltration, but this is whereby you have a filter that is connected from the artery and then backflow through the vein. I do not have experience about this, but people who have maybe experience about it, they can mention something about it at the end of the presentation. So dialysis supplies, many countries and many centers suffered from serious shortage of dialysis supplies because of the global nature of the pandemic. And some of the ways that people have survived and units have survived to provide some aspect of care is by having aggressive non-dialytic medical therapies. And Professor McLeod alluded to this yesterday, by zealous fluid and electrolyte management, so that if your patient just needs dialysis for fluid removal or for just potassium removal, then consider zealous fluid and electrolyte management, aggressive diuretics, potassium binders, and even oral and IV alkali. Then there's this issue of permissive underdialysis. Of course, this is in short saying you are not offering optimal dialysis, but you are giving a patient some dialysis to maintain them so that another patient can be able to dialyze. Self-preparation of CRLT replacement fluids and use of PD fluids as replacement fluids. These are some of the aspects that people have used. Our experience at KU in March last year was that we kept hoping that Mbagathi will not be full. But sooner or later, Mbagathi was full. And I think for a few days, we kept getting notices from the ministry, patients with COVID are coming, patients, and we are hoping they will not come. There was a lot of uncertainties that time, but eventually the patient came, and we quickly realized that these extrapulmonary manifestations were quite many, especially thrombosis, myocarditis, and renal and the AKI. And when our first patient was discovered to have AKI, they were in ICU, and the ICU did not have piped water for performing dialysis. And I remember I was in a crisis meeting on how to sort this patient. And fortunately, we had CRLT machines that were there, and we got water supplies, replacement fluid. Some we got from Mata and others from Kenyatta, and we were able to dialyze our first patient. The patient did not make it, but at least we had been able to offer them the renal replacement therapy the patient needed. And within the week, we had 2 other patients. So after we started this CRLT for this patient, we also realized most facilities were not able to even sell the water, the replacement fluids they had, and they say they were in short supply. So within a week, we had to call the engineers and pipe the water to the ICU, and it was done within about 2 days, and we managed to get 2 water points to the ICU, and we were able to start providing this dialysis. Of course, we had issues of staff convincing the renal nurses to start dialyzing these patients. That time, there were a lot of uncertainties about COVID, how it spread, and even the PPEs, the donning and the doffing. So that took a lot of energy and psychological effort to just get the teams to be there. And after a short time, we had such many patients that we had to start doing like a form of dialysis rationing. This is whereby we would have wanted to dialyze you for 4 hours, but we have so many patients who are waiting, so that we have to give a chance to another patient. So those were some of the challenges that we experienced. We also had a serious shortage of nurses. And remember, we still had the patient who had end-stage renal disease who had undergoing dialysis. Even getting the nurses to do that kind of dialysis, it was very difficult. And word spread around, KU is offering dialysis for COVID patients. And we started getting patients as far as from Machakos, and we had very limited resources. Let me quickly run through this. So of course, this is the other burden that we experienced, is that the patient on maintenance hemodialysis, not only in KU, but all over the country and all over the world, they are a high risk group because they are older, they have comorbidities, and they are in an immunosuppressed state. They may not be able to present with the usual signs and symptoms of COVID-19. They are a risk to staff. The staff are also a risk to them, and they are a risk to other patients. They have heightened exposure because they have to come twice or thrice a week to the hospital. They have lengthy hospital stays, and even the transportation, many of them could not afford the recommended private means of coming to the hospital, and many came by matatu. So this put them at an extra risk, and several studies have shown that the risk of COVID is higher. And even when you compare the various modalities of renal replacement therapy, the hemodialysis patients risk is far much more compared to the transplant group, and even, of course, the general population. So HD facilities can be hospital-based or community-based. And initially, the community-based and standalone units were referring these patients to the hospital. And this was, of course, easy. Unakohoa kidogo, you have a fever, go to this and this hospital. Go to so-and-so hospital. That's where they are screening and offering people dialysis with COVID. But unfortunately, this was not sustainable, and it is not sustainable. And I believe all of us by now agree that all the facilities, whether you are offering hospital or community-based facilities, is that more and more units have had to undertake these responsibilities. Of course, it's not the perfect situation, but facilities have had to look at ways of providing dialysis to their patients, or think of a clustered designated outpatient area. I don't think we have been that organized as a country where we dedicated a certain facility in a certain region and said this is where they'll carry out COVID-19 positive. Initially at KU, we had a lot of this, whereby many patients had a lot of delays because many facilities either declined to offer dialysis to patients who had symptoms, and we actually realized a lot of patients, actually died from pulmonary edema and not necessarily COVID. So there are many perspectives to this. I'll rush through this because of time. And to try and manage the resources through contingency planning, there has been issues of mitigating risks. That is meaning you have accepted the risk. You are now just dealing with the risk. And I think there were CDC guidelines on this, and even our very own Kenya Renal Association gave a guideline to guide the units on what to do during this epidemic. And I'll just summarize them very quickly. These aspects involved use of PPE, screening of the patient, patient placement, patient instructions, patient environment, and complications. Allow me to move a bit quickly on this. So the standard contact and droplet precaution should still be taken. People are getting less worried. People are getting less worried now that they are vaccinated. Na wanasema wameelewa COVID zaidi. But isolation gowns, gloves, eye protection, masks, and eye shields should be utilized, and we should use them in a way that is sustainable in the long term. Patients who are suspected, ideally patients with symptoms, they should be asked to inform the units ahead of time so that they can be, so that the units can prepare for them and decide. But patients who are suspected to have COVID and they are stable, they should be tested, okay? They should be tested and isolated and kept outside the dialysis facility. Now with rapid antigen testing, this is much faster. But for unstable patients who are still suspected, they should be dialyzed either in a holding isolation area, or they should be dialyzed in the last shift of the day, and preferably somebody added in the farthest corner. If they are confirmed to have COVID-19, then the patient should be dialyzed and isolated in a different place, preferably in a separate room with a door closed. And this should not be in the hepatitis B isolation area. If there's no separate room is available, then patients with COVID-19 should be put in a cohort on a designated isolation shift, preferably the last or the night shift, or to refer to a designated COVID-19 facility. Of course, after some time, you all realize it is difficult to refer all your patients with COVID-19. If both asymptomatic and symptomatic patient must be treated at the same time, then the symptomatic patient, they should be treated in the farthest place, maybe at a corner where you can, or the end of the row, and preferably set a 6 feet difference, separation between the symptomatic and the asymptomatic patient. This still continues to be an issue in many facilities. The patient should not miss their dialysis sessions. This has been an issue, especially when there were issues of lockdown, travel advisories, and also fear of coming to the hospital. And this led to more complications and death as patients came with pulmonary edema, and uremia. So let the patient observe respiratory hygiene. The patient environment should be addressed by routine disinfection practices, and the personnel who do it, they should also put the PPEs. Other measures, as I finish, is permissive under dialysis of stable patients. Of course, many of our patients were already dialyzing twice a week. It was not possible to reduce that, but those who are doing 3, it could be done to 2, and maybe reduce the hours from 4 to 3 to allow more patients to dialyze. Of course, there are places and countries where they could be able to encourage home dialysis and telemedicine. So communication is important so that the organizations like KRA and others and the government can keep knowing the extent of the epidemic for the sake of planning. Just like initially, people never thought this renal issue is a big issue, but now we understand. So in conclusion is that standards of care in a crisis time, people have tried to look at it, and can be summarized as it's an adaptive spaces. Staff and supplies are not consistent with the usual standards of care, but provide sufficiency of care in the setting of a catastrophic disaster. That is, provide the best possible care of patients given in circumstances and resources available. So the crisis capacity activation constitutes a significant adjustment of standards of care. So what we are saying is that we know we may not be perfect, but we should try and offer the best that we can to our patient as we protect the staff during this epidemic. And we appreciate that AKI is common and it has a high mortality, and we need to reorganize our personnel and dialysis methods and supplies. And our patients on maintenance hemodialysis, they are a vulnerable group, and we have to plan and anticipate for their needs. Thank you very much for listening.